Hi, everybody. Welcome. I'm glad you could all come to the Pre-Med Club meeting today. Today, we have one of our former students who is going to speak. I do want to say that if you are a current student at Shawnee State in the Pre-Med program and you haven't joined Pre-Med Club, I hope that you will do so. You can contact me or Abraham Heimbach or any of the other Pre-Med Club officers in order to, join Pre-Med Club. And during our talk today, I think, most people's microphones have been muted, so you won't be able to actually speak during the session, but you can type your questions into the chat room and we'll see that they get to our speaker so we can answer any questions you may have. But once again, thank you for coming, and I'm going to turn things over now to our Pre-Med Club President, Abraham Heimbach.
Thank you, Dr. Burns. I'm Abraham, and okay, so today we should be having more people since this is a public event. We have the honor of having Dr. Cody Horn. Like Dr. Burns said, he's an alum from Shawnee, and he's here to share his professional life experiences with us. For our pre-med students, please be making sure to think about what you would like to ask him about his professional choices and some of his opinions on his academic and professional career. For anyone else, please make sure that you ask questions to inform yourself on the current state of medicine and infectious disease in the Corona era. Yes, we have a YouTube channel that we will be posting this to. It is Shawnee. I'm typing it in the chat for all of you. State Pre-Med Club, and that's where we're going to be uploading this to later. And if you have any questions, I can type my school email in here to allow you to ask me questions regarding that later. Now, without any further ado, we have Dr. Cody Horn.
All right, thanks, Abraham. Thanks for having me, Dr. Burns. Abraham, pleasure. So just a few housekeeping things. Pleasure to be here. My thoughts are my own today. It does not represent my program, my university, anything like that. These are purely my experiences and not those of my cohorts, okay? So I'll try to stay apolitical in a very politically controlled climate of COVID-19. I'm going to do my best at that to stay in the middle of everything, okay? It's very informal. I'll just be talking. I'm not reading off of anything, so I'll just probably ramble about what, the questions that you had previously given to me or anything that comes in the side, I'll just talk about. So very informal. So with that, I'll just go ahead and get started. Cody Horn, Infectious Disease PGY 5, which means I graduated from medical school in 2016, and I'm in my 5th year of postgraduate training. I'm coming to you from beautiful Tampa, Florida at Moffitt Cancer Center, where I'm doing bone marrow transplants and infectious disease with cancer patients this month. And I've got a beautiful wife, very supportive wife, Madeline, and 2 kids. So it's possible to maintain everything through all the training. 8-week-old daughter and a 2-year-old daughter too. So life is possible with medicine, though it is stressful at times, which is imaginably so. So I'm from Southern Ohio. I went to high school in Chillicothe, Ohio. That's where I'm from. From there, I went to Shawnee State because I knew they had a good program for pre-med and good biology program. Had a pretty good reputation for getting people into medical school. So definitely wanted to go there. And so I did, got very involved in all the pre-med stuff. I was Tri-Beta president my senior year there. I did treasurer for pre-med club, I think, and then there's a chemistry club I think I may have done something with a long time ago too, but definitely was very involved in all those things. Really took a liking to microbiology course, which Dr. Burns was over the advanced microbiology section. Parasitology was one of my favorite courses as well there, so just really kind of focused in on the microbiology aspect of the biology program. Did some research with Bordetella bronchoseptic with Dr. Burns, which was very good to get some bench work in, kind of teach me about research and actually use my hands, which I really enjoyed there. So I very much enjoyed the time at Shawnee. Felt like it was very, I certainly wouldn't have gone here without going to Shawnee first. I mean, I could have ended up somewhere else. I don't know if I would have been as happy or as, I guess in my mind, as successful as I am currently. So it definitely, Dr. Burns was a giant rock for me to get here. So very, very appreciative of all the attendings down there, Dr. Beddick and Dr. Oliver and Dr. Burns to get me here. So Shawnee State was a great time. I'm a terrible test taker and always have been, with the exception of the coursework, but standardized test taking was terrible for me always. And so I didn't get into med school my first time. It was pretty shattering, but my Mcat scores were not as up to what a lot of people did. So I got into the post-baccalaureate program at OU, which is where I wanted to go initially anyway. So that worked out well, and then ended up getting in the next year because I did very well in my coursework, as I always have. It's just that standardized test taking. And so I made it into Ohio University. And so with that, if you don't get in, it's fine. Some people are not gifted in test taking. It doesn't mean that you're any less intellectually inclined as anybody else. It just means you're a terrible test taker. And it's followed me everywhere. As for, your in training exams for internal medicine boards, which I passed beautifully, no issue there, but still in training exams and the standardized testing is terrible. But at my time in Ohio University was great as well. The first year is very difficult. You're just studying for 20 hours a day, it seemed like, and you do that for 2 years before you even really get to any clinical work. And so you're just keeping wondering, why am I doing this? Why am I doing this? Because I'm just miserable. I'm studying all the time. It's terrible. And then you get the third year and then it's all right. This is what I studied for, nonstop for. And it kind of gets a little bit easier your second year and your third year in the medical school. You kind of let up a little bit. You're doing fine in the courses. They do not want you to fail because there's got a lot invested in you. And so they really take the time to make sure that you're doing well with your coursework. If you need any help, then that's widely available to you for anything. And so that was a good experience to go to OU. And I initially said I wanted to go to OU even before I took MCAT. It was purely because Southern Ohio has a lot of DO physicians as well as MD2. But when I shadow people, I always enjoyed the interaction of the DO with the patients. And that's not to say that the MDs have a worse bedside manner or anything else. It just seemed like the patients responded well to the DO and they related well. And so that's kind of what pushed me to go that route, because you can know everything in the book and you can tell your patients to do this, but if they don't trust you and if they don't interact well with you, then they're not going to do it. And at the end of the day, that's what it's about, is to make sure that you have a good rapport with your patients to make sure that they're doing the best for themselves. And so that's the biggest reason probably why I wanted to go to OU and to do the DO thing. So in third year of medical school, you start to do more rotations, your surgery, your OB-GYN, everything like that. And the biggest thing is, do you want to do surgery or do you not want to do surgery? That's the first routes in the track you need to take to rule it out. Okay, I don't want to do surgery. I like sleeping too much. I want to think about what I'm going to do rather than, I'm going to go in there and operate and walk out. And then wave at them at the door the next day. That really wasn't me. So I enjoyed internal medicine. Not my first time through. I thought it was boring, but it grew on me as the year went on, and learned a little bit more about internal medicine, what it is when you rotate in your, the cardiology or pulmonology or whatnot, different rotations there. And then I liked emergency medicine. So it was, do I want to do internal medicine or do I want to do emergency medicine? And it kind of gets to that point too, where you got to say, okay, I'm going to commit. And that's difficult to do. Very both different fields. So I ended up doing internal medicine. because I like to think about how the patient's doing afterwards. You get to use a lot of different studies that you learn in medical school. You learn everything. I mean, you got to take into consideration the heart, the lungs, the kidneys, everything, acid base, rather than more algorithmic thinking of what the emergency medicine is. And it's more if this, then that. You know, if chest pain, get EKG, get these things. Stabilize, ship them up. And that's where we intercept the patients is, you know, they're stabilized, and then we do the work thereafter. So very appreciative of internal medicine colleagues. And I enjoy interacting with them. Probably internal medicine and emergency medicine usually gets along quite well together outside the hospital. But I enjoyed that. So I did my internal medicine at UF in Jacksonville, Florida. It was my first choice. I really enjoyed the program there. The program director there is actually a DO. He's a very nice guy, very well respected in the community. So that was a good 3 years. And the first year is absolutely dreadful, but you can make it through it. It's not sleeping. It's like being back in medical school with a practicing license, which is the scariest thing, actually. So it gets very real. And then whenever you're in internal medicine, you decide, okay, do I want to do hospitalist? Do I just want to admit and discharge and consult the people that need to be brought in, you know, the heart doctors, the lung doctors, and for internal medicine, you go through all these different fields with, you know, heart and lungs and kidneys. And at the end of the 3 years, you make a decision. What do I want to do? Do I want to stop? And do I want to do the admissions, manage the patients, medicines, and be kind of a primary care inside the hospital? Or do I want to further continue and specialize something else to the hearts, the lungs? And since I've always really enjoyed the infectious disease side, it's where I thought I would end up at the beginning of it. And then in the middle of it, you're just done. You want to be out making money. You want to not do it another 2 years. And that's the toughest decision to make is, do I stop or do I go forward and knowing that the next 2 years are probably going to be the longest 2 years of my life when my friends are out snowboarding in Colorado or, you know, in Switzerland and enjoying bike riding on the Alps, and I'm still studying and working here. So that's the toughest thing. But I've always really enjoyed the ID side, and so I decided to continue on that and to do infectious disease. It's very inclusive with everything. You have to be a radiologist, you have to be a nephrologist, you have to be a cardiologist, you have to be a pulmonologist. You look at all the scans, you think of all the weird things, and it's very enjoyable. There was a case yesterday behind me on the board was pretty much the epitome of why I came into why I wanted to do infectious disease. It's a gentleman who came in with a necrotic lesion on his liver, and he's been everywhere in the world, literally. And his occupation is very high risk for everything too. So you have to think about bacteria, you have to think about parasites, you have to think about protozoa, you have to think about fungal issues in this gentleman. And that kind of summed up the reason why I wanted to make sure that I was using my brain. I enjoy thinking about all these things. Oh, what's endemic infection in this part, you know, in Laos or in the Philippines or wherever this guy's going? What is he at risk for, and what fits the bill with his current clinical condition? So it's very, very tough to think about all these things, but it's intellectually stimulating, and that's what I want. I want an adaptable field where it's always changing. It's cardiology. You're always going to have a new medication, and stuff like that. But cardiology, the heart's the heart, right? The heart's been the heart for a long time. And it kind of brings us into the next talk, is that infectious disease is always changing, and hence the current pandemic. And that's, unfortunately, I mean, it's very exciting, but it's also very scary. But we knew as a medical community, this was eventually going to happen, to where we have a global pandemic. And, you know, we've had MERS, we've had SARS-1, but this is something completely new. And this is the reason why I got into infectious diseases, because it's always changing. It is always changing. It's always going to be something different in the next 50 years from now. We're going to look back on this and it's going to be something else. And we'll look back and, oh yeah, I remember the SARS-CoV-2 pandemic, and now it's something else. It's just always different. And so I think I answered the questions that my history. And so to get into the COVID stuff, it was asked, what best prepared you in your medical learning and fellowship for this pandemic? In what ways did you feel unprepared? That's numerous. And how did you compensate for those? So what best prepared me for the current pandemic is being adaptable. And that's not something you teach, that's inherent. And I feel like anybody who goes to medical school has to be adaptable. You're always going through different rotations. You're always doing the surgery. You're always doing emergency medicine, internal medicine. So you learn to kind of shift and change as the environment around you changes. You got to be very fluid. And so that is what's best prepared me. I feel like that being adaptable and being aware of everything. And then also with just clinical training, probably ICU. I very much enjoyed my intensive care rotations in internal medicine. And I interviewed at the Infectious Disease Critical Care hospitals around the country. That's a dual program. It's 3 years. You do 2 years ID, and then you do a year critical care. But in the end, I decided not to do that. I very much enjoyed working on my hands, doing central lines, thinking on the fly, and life or death situations. But it wouldn't have been smart for family to do that. Probably it would have been a very stressful lifestyle. So I ultimately decided to forego that. But that preparation in the intensive care units, where you have people dying left and right. And one night I had 3 codes at once, simultaneously, 3 different rooms. And, we calling emergency medicine to come up and help us because I'm doing a line in here, moving to the next room, doing a line, moving to the next room, doing a central line is what I'm talking about. And so that's very stressful, but it's, you don't plan for that. And so that's kind of the best clinical thing that I've done is, intensive care rotations very much prepare me for this, because you can't prepare for this. And how did let's see, in what ways do you feel unprepared? From the very first time I donned and doffed the gowns and the mask and everything, was unprepared from the start. I mean, the level of anxiety that you have whenever you're putting on the N95 the first time, and the face shield and the gown, and I put on my gloves now, I take off my gloves, and then you're very unprepared. So you're having people walk you through how to put on your gown, how to take off your gown without infecting you and everyone else around you. It's the very start. And then we're flying completely blind. We don't know what works. We don't know what doesn't work. We don't, is this going to make the patient worse? Is this going to make the patient better? Just the level of information to start out with was probably less than nothing. We think with the first times we were just flying completely blind. And how did he compensate? Well, you learn how to don and doff your gown. You learn from those around you. You learn from your friends that are in infectious disease with you, who are having different experiences. You join a lot of blogs. Oh yeah, this patient presented with this. This is a different finding. Oh, this is new. This rash is consistent with COVID. And that's how you compensate, is to read. And at first there was no literature available. There's no randomized controlled trials that take months and sometimes years to do. It's clinical vignettes and anecdotal evidence at very best about what to do. Oh, this worked for me. Maybe it'll work for them. We try it out, and then kind of snowballs from there about what to do. So learning from your peers' mistakes and learning from your peers' successes helped me combat a little bit more about what we were doing and get more comfortable with the field. The next one's very difficult to answer politically, so I'm going to try. There's a lot of fear in the public regarding the virus. What fear or amount of fear is rational? What is irrational, and how should physicians deal with it? So that's a good one. So it's a big deal. As one of my attendings just put it the other day, it's a big deal. It's terrible. It's no joke. We've seen a lot of suffering from all ages. I've seen a 25-year-old healthy guy who was playing basketball have a heart attack from it. I've seen bilateral massive pulmonary emboli, which are lung clots, in a 37-year-old. I've seen an intracranial hemorrhage and a ischemic stroke in the same patient on different sides of the brain. It's completely, everything is gloves off for this. It is a big deal. It's very scary. And so fear is, I like to use the word awareness more than fear. I feel like fear is not a good thing. COVID is, I equate it to a natural disaster. You respect the tornadoes, you respect the hurricanes, and it's the same thing here. Like, if you're aware of it and you respect it, then that's a little bit different than fear, and you can kind of tailor your life towards that. It's here, it's happening. Not to say that you got to wall off and shelter in place the entire time, but be aware of it and respect the catastrophic nature of it. So irrationally, the only way I feel like you can be irrational is to not respect it, because it's, like I said, a healthy 25-year-old guy, heart attack, massive heart attack from it, and had no other problems. So that's, that just doesn't happen when you're positive for this virus. And rationally, yeah, you can't wall off. We eventually do need to restart the economy. It's not, you can't run and hide forever. You do have to face your problems, face your fears. I mean, it's like the bully in the schoolyard. You got to go to school at some point. So how do you combat that? You just take things seriously, wash your hands often. Masks do help. There's a good study in Nature from May of this year by Nancy Leung, Leung. That's a good read. Masks do help. And so by respecting the virus, taking precautions, that is probably the best way to deal with that in my mind. Let's see. Someone else asked, has SARS-CoV-2 made patient interactions more difficult for you? Yes. And how much interactions do you have with medical lab techs and scientists? So very, very closely, actually, in the very beginning. There was a good read from the Washington Post, just got out last week, I think. And Tampa General Hospital was the focus on it. And the medical tech, or the basically lab manager with us, was working very, very, very closely with the infectious disease team. And that's focused in on the article. So at first we do work very close, hand in hand, trying to make assays. What do we do with these assays? How do we quantify them? What do they mean? What's a positive mean? What's a negative mean? What's in between? So at first we had a lot of interaction with them. Not so much anymore, because it's, you're positive. Okay, thank you. We'll isolate the patient, and that's pretty much the end of the conversation now. Patient interactions are a lot different. I mean, it's tough because now you can see from here up, right? I have my visor on, I have my mask. So you're just knowing your doctors from the eyes up. And that's COVID patients and that's non-COVID patients. So you got to treat them both the same. So it's tough. It makes that personalization that I so much appreciated in the very beginning about, being a DO and talking to the patient, being close with the patient. It kind of takes that out, and then everyone's afraid to talk. If you have the virus, the provider doesn't want to be in the room for very long, obvious reasons. And so that interaction that's kind of difficult, because we're trying to give them the best care that we can, but you're kind of at the same light trying to rush things. So that's difficult, but patient care interactions have definitely gotten decreased just because of the virus, unfortunately. Um, was that the other questions? Why infectious disease? I've already answered that. Yeah, I think it's a big deal. And hopefully the public starts to appreciate that more and more. And that's what it sucks, that it's made into a political thing of mask versus no mask, because that shouldn't even be a point of interest. However, people make it a point of interest. And it's sad because us physicians suffer from it. And that's one question I didn't ask, was how should physicians deal with that? Well, we roll with the punches. With these events that have a lot of people who spread it, and ultimately we're the ones that suffer. So we just say, it's more of a practice what I preach kind of thing too, that I need to wash my hands off, and I do. I carry sanitizer with me. I always wear a mask when I go out. I wear an N95 actually, always when I go out. I try to keep my distance. I try to not go out I used to love going out and playing pool and having fun for an hour, coming back. I can't do that. I haven't done that for, since February, because it's not safe. And so we need to make sure that the public trusts us and that we're doing the same things that we're telling them not to do, and that we should be doing the same thing. But when people don't abide by that, we ultimately just suffer. And, then I get pages in the middle of the night because this person's crashing with COVID, and, what else do I do? I can't really do a whole lot. So that's what makes it most difficult, I feel like. So, what else? Anything else?
I would encourage everybody to type your questions into the chat room if you
sure.
have questions for Dr. Horn. Also, while we're waiting on people to ask questions, just maybe tell us some more about your personal experiences there at the hospital during this, time of COVID and, everything that's going on.
Yeah, it's a lot different now than what it was starting out, because I got the new fellows have a different experience because they're coming into it knowing that there's a virus out there. I got 6 months into my training before we learned about some of it. And then even then it was, we weren't sure about it. When was this a big deal? Is this not a big deal? And then it finally hit. And I was in the, pretty much the middle of my first year of training. So I got to experience both sides of that. And it's night and day different. One thing I've learned about is, the environment, the scientific community is always changing. And so we were at first, like I said, we're not sure, is this a big deal? Is this, do we need to be scared or not to be scared? And at first, we thought it was a flu. We thought it was, this is going to be just like anything else. And not to say we didn't take it seriously, but I think we underplayed it quite a bit, and it way overshot how we were expecting to manage it, and got very, very out of control very fast. And that was something different. And so at first it's not a big deal. And then it's, no, you don't need to wear masks, because we weren't sure how many people had at that time. And then people started coming out more and more. And then now you should wear masks. That's what I don't feel the general public is taking into consideration, is that if we're not adapting, then what? We're still treating mercury, or we're still treating syphilis with mercury. That's why science is what it is. Trust science. Science adapts. We adapt our recommendations and our outlook based off of what science tells us. Otherwise, we're still drilling holes in the head to cure epilepsy. That's what science does. And so for the general public to come back and say, well, 2 months ago you said no mask, and now you're saying mask. That's because science is alive. Science is adaptable, and we need to be adaptable too. And so that's one of the things that I learned about all of this, is that what we thought today, it can change in the morning by a simple paper, by an interaction, by anything. Is that science is very fluid, very fluid. My mother asked, was it worth it? Would you go through it all again? And it depends on what day you ask me that. I'd say during medical school, no. I wouldn't go through it, because you want to quit every day, and why am I doing this to myself? It's terrible. I'm on 3 blood pressure medications. Is it worth it? Looking back now, as I graduate in 8 months, yeah, I think it's worth it. But it's one day at a time. It's one pant leg at a time. So yes, Mother, I probably would go through it again. Katie asked, how has life being a physician affected your personal life and relationships? Man, if my wife is on, she'd love to weigh in on that. Why do you think it's more likely for doctors to marry other doctors? That's tough. Personal life, definitely affected. Life is very stressful as a doctor. And it depends on which phase it is. I mean, she was with me from first year of medical school to now. And yeah, it's like any other relationship. It has ups and downs, sideways, up, it changes just like any other relationship, but the level of stress I feel like is very difficult at some points, and she gets that. And fortunately, she's a nurse practitioner, so we both speak the same language, and so that's kind of nice. So I think it's more likely that we marry other doctors, because that's what we see. The doctor and the nurse, the doctor and the doctor. I think it's just because we're there, we're in the hospital, and we don't leave the hospital. So of course, it's really your only interaction is this is who we see. It's your cohorts, and so that's kind of, I think that's why that is, rather than going out and meeting someone else. We're always at the hospital, or we're always at school or something. So I feel like that's it. But like I said, we have 2 kids, so obviously marriages can survive medical school, and residency, as difficult as it is sometimes. It's, at the end of the day, this is just a job, and you got to put your job less than anything else. And so that's first and foremost, I'm a husband, then I'm a dad, and then I'm a doctor. And I tell that when I was interviewing for positions, that's the way it is. I mean, at the end of the day, I take off my coat, but I still have on my dad hat or my husband hat. So it's definitely possible to keep all that. My question is, what mechanism does SARS-CoV-2 use in order to cause such a wide range of issues? So that's a difficult one to answer. There is an ACE2 receptor on the SARS-CoV virus that uses the ACE2 receptor to go inside the cells, and that we're still figuring out. Do we target the receptor? How do we do this? How do we prevent this from attaching in? So initially, that's why we're using lisinopril, which is an ACE angiotensin converting enzyme, to see if it works with the virus. Well, it doesn't. So we're still finding out a lot about that. And that's the tough thing, is that we don't know. And that's why right now we're using steroids. We're using a nucleic acid terminator, which is the remdesivir, to kind of combat that. And so we know that there's 2 phases to the virus. The first phase is the host inflammation stage. The individual is getting the virus, and then in about 7 days it switches to a different phase, and that's where everything goes crazy. As that 7 to 14 days generally is where it gets worse, and that's where we're seeing the issues, where people come in and get intubated and can't breathe. Is that the level of inflammation that causes is ridiculous. And we don't know, as far as I know, why it causes such a wide range of issues. These people bleed, these people clot, this person has this manifestation. This is only skin, a lot of it. Some people only have nausea, vomiting, diarrhea, and nothing else. Some people don't have any symptoms. We don't know, as far as I'm aware of. It's defied all of medicine. It defies everything that we know about medicine. So hopefully in the near future, we'll know a little bit more. But I think right now we're still kind of flying blind about, how this is affecting things. And that's why we're still doing some therapies. Does this work? Does this work? Does this work? Because, long story short, not sure. How do you encourage patients who are at higher risk to take the proper precautions? Many people do not fact check. That is very much true. And since we are learning new things about the virus, so higher risk people, the same thing, don't go out if you don't have to. If you're high risk and say you're immunosuppressed, you're You're on steroids, you're on immunomodulators. Don't go out if you don't have to. Use curbside pickup, stuff like that. If you do go out, mask, gloves. Be safe with family, because everyone thinks family's safe, and that's not the way it is. Don't go to church, because that's seen a lot of issues with that. Just kind of be practically smart about it. And it's very difficult to say, don't live your life, because nobody wants to be told what to do. So I'm going to go out and do it. I'm going to go to the baseball game. I'm going to go to this. And then that's where they get in trouble at. And so just be practical. Do you think that we are now living, do you think the way we are now living, i.e. mask and social distance, will continue to be in place for years, even to come after COVID-19? Probably so. My wife asked me that just 2 or 3 nights ago. I think the world has changed, and I don't know for how long it's going to be like that, but yeah, I do. I feel like it's going to be in place. People are going to be very shy after this. I mean, not after this. I feel like the COVID's not going away, but in the next few years, feel like I'm a very interactive person. I like to hug. I like to shake hands. That's not the world now, and I don't think it's going to be the world in the future either. I know that COVID is the same kind of virus as chickenpox, but is there any evidence that COVID might behave similarly? That is there any evidence that may persist in the body and develop post-infection and repeat later in life in a different form? It's way too early for that to tell. We don't know. Chickenpox is a neurovirus, and so COVID is not a neurovirus. That's why chickenpox comes out later in life. However, it brings up another point: is second reinfection going to be a lot worse than the first infection? Like different viruses, like chikungunya, people who get it the first time, they might have really bad muscle pain. You feel like death for a few days, and then if you get it again, you can hemorrhage and die. So that's the concern: is that what is a second infection going to be different than a primary infection? We don't know. Reports last week say that the first case just came out of reinfection, where an individual got it the first time and then got it again months later. So that is up in the air. Hopefully it's not the hemorrhage and die, but you don't know. Your immune system gets stimulated to things, and then initially you recover, and then you get it again and it gets worse. But hopefully that's not the case. Who knows? That remains to be seen. Is my hospital equipped to handle the volume of patients? Have you had issues in making sure you have the right equipment and tests? Fortunately, Tampa Gen is handled it like a champ. It's an 1,100 plus bed hospital that is got a lot of state-of-the-art everything. And I feel like I never had issues with having personal protective gear there, which is a lot of hospitals can't say that, but I was fortunate to have my gowns. I had my masks. We tried to minimize how much exposure we went. So if I was going in the room, the attending wouldn't, and vice versa, just to kind of preserve gear. But now that we know that it's okay, we're not preserving as much, and we're making sure that the patients get the interaction that they need. Have paywalls on academic journals impeded your treatment of SARS-CoV-2 or treatment of the disease in general? Also, how similar has SARS-CoV-2 been on SARS-CoV-1 or MERS? So a bit different, right? I bet most people here don't even know what MERS is. And then SARS-CoV-2 was the SARS back in it was the early 2000s. Quite different, right? So if you haven't heard of MERS, the Middle Eastern Respiratory Syndrome, it's virus from camels, and it's a lot different than this. Same symptoms, much higher mortality, and then SARS-CoV-1, not too familiar with, as fortunately I was still a kid when that happened, and I've never seen a case of regular SARS or MERS. SARS-CoV-1's mortality rate was a bit lower than what this one is. I do know that. And then the R naught factor, which is infectivity spread, was a bit different too. The same with MERS. Academic paywalls and academic journals impeded treatment. I have no idea. It's above my pay grade. But I feel like we're putting out we're putting out a good amount of information as much as we can, and a lot of these journals aren't charging. You could go online now and look at New England Journal of Medicine COVID papers, and it's not charging because we're trying to put as much information out as we can, so that way we can learn, and that I don't think people aside from politicians are trying to benefit from COVID. I feel like most clinicians, scientists want to share their experiences because we're all in this together, and we're trying to figure this out. So anything else? I'm still trying to answer these as best I can. All right. Do you have any idea of the progress in the vaccine being made? We do not know enough about the strains and how it interacts. How fast do you think an effective vaccine can be made during this confusing time? Yeah, that's a great question. Vaccines take years to develop. And regardless of who tells you, yeah, we're going to have a vaccine here soon, no. The vaccine needs to go through the proper trials. If you don't, then that's bad. We need to make sure that we go through the proper steps to make sure it's a safe, effective vaccine. And that's probably a ways in the future. There's many different strains of this that we know of now. And one of the ways you can evidence that is that you compare New York mortality rate of 11, 12% at the time to Florida's mortality rate, which is 2 or 3%. Fortunately, Florida didn't get the New York strain, which is the Milan strain, and that's the 11 or 12% mortality rate for that one. We got the Wuhan, which was a little bit less strain. I've read reports of different strains coming out that are more infective and less have a decreased mortality, but there's a lot of different strains. So trying to tackle that into a vaccine gets difficult, and then it might end up being like the influenza, where you have all these different strains. And the same thing is that the virus is very adaptable, and so that's the issue, is that the viruses can change. Genetic drift, genetic shift brings back the immunological background on that this may be a different strain later in the year, even in the same season that it was the beginning. So who knows? Probably years away from an effective vaccine. But again, that's stuff that I don't have the crystal ball to tell you that answer. Mentioned reinfectivity, SARS-CoV-2. Is there any validity of the claims holding up the immunity for 3 months, or can we hold immunity for SARS-CoV-2 for long periods of time? Again, we're still early in the whole virus thing. There's been studies on macaque monkeys that state that there's no immunity. There's some saying that there is immunity. What we do know is that not everyone mounts an antibody response to it, and that's why we've been giving the convalescent plasma, which is some South America hemorrhagic fevers we give it to, and it's kind of shows a mortality benefit there. And it's just giving the patient antibodies from someone else who got infected with it and survived and produced antibodies. Not everyone produces antibodies. And if you do produce antibodies, we know that the length of time that your antibodies are in your body, about 6 months at most, as far as now, and that immunology wanes over time. The less symptomatic you are, the lower antibody titers you have, and the deeper you are, say you have pneumonia, the more you're going to have if you do produce them at all. And so at the very beginning of all this, we did the nasal swabs, and then the issue was that you could have 2 or 3 swabs that are negative, and the person gets intubated, and we do a bronchoscopy where you look down into the lungs with a camera and take fluid out, and that one's positive. So we had a few of those cases where the deeper you go to take your sample, the better yield it is. And so people produce antibodies differently into different levels of them, different titers, and they don't last as long. And so that's the issue with immunity with COVID-2, is that we don't know how long you're going to have them, but for the data that we have now, it's not permanent. What did you do in your gap year that led to your acceptance in medical school? I rocked it. So I did a post-baccalaureate program into OU. I don't know if they still have that, but it was myself and 12 other people where we did invertebrate anatomy, we did neuroanatomy, we did immunology, general micro, general virology. I don't think biochemistry was in there, but it's basically master's classes for to make sure that you're. I don't even know if it's to make sure that you can get into medical school, because at that point you graduated with your BS. You can pass courses. I think it's just a way for them to say, hey, yeah, welcome in. We have a spot for you now. Everyone that I went into that program with are doing very well now. They're running ICUs. They're great hospitalists. So that's what I did in my gap year, and then got in, and same thing, got in, got out. What did you do? Why do you think some regions are more heavily affected by SARS-CoV-2 than others, both on national and international scale? That goes back to a lot of policies in place too, and then different strains that I mentioned. New York got the Mulan strain, we got the Wuhan strain, and different populations and communities have different risk factors that could predispose them to do worse than others: high blood pressure, diabetes, drug use, alcohol use, different people, different areas kind of typically go together with risk factors. And so also with that is being able to isolate more. In New York City, it's kind of tough to isolate whenever you're jam-packed in a subway, whenever you're walking in the street, whereas compared to rural Ohio, where now your guys' cases are shooting up, where ours have been and still are. But it's a little easier to isolate yourselves in a small town than it is to go to New York City or Miami or Tampa even, and that's where we're getting way more cases than those heavier hitting populations where they're packed close together and they're unable to actually distance themselves as they properly can. Sanitizing a subway station, I guess that's not practical. So that's one of the issues too, is that those areas just predisposed to more infections, unfortunately. Anything else? Do you think college campuses should be having in-person classes? I was waiting for that one to come up. That's very difficult, and I feel that it's tough. I mean, how can you be a chemist and not, go into the chemistry lab? How can you be a doctor and not go into, a patient's room or go into lectures that you have to interact with people? It's very difficult to do, and that's a politician question, not mine. It's very difficult to make sure that everyone's safe to go back to campus. They initially, I know all the college campuses here, UF was doing it, USF was doing no swabs before you go in to make sure that you're negative, but 2 weeks later you could be positive, who knows? That's just a personal decision. Is that, do you feel comfortable going to a university that has in-person classes, or should it just be online now? It's tough. It's tough to be safe. If you do it effectively, do it smart, space out, sanitize in, out of the room, disinfect the desks, and if the class has masks, then I feel like it could be done safely. But class sizes will definitely be decreased. Do you think the pandemic can bring more awareness to the implementation of Healthy People 2030, building a more holistic approach to health promotion? I'm trying to think on that one. I feel like the public awareness is what they want it to be. People try to be oblivious, and it doesn't exist. It's a hoax, or they're walled off, and then they believe everything that the media tells them. I don't know. I feel, yeah. I don't know if this is going to help with the healthy people 2030 or not. It depends on what the public's going to want to do with them. What people have you seen affected the most besides the elderly population? What risk factors have you seen the most seem to be most present? Is plasma an effective treatment? And have you had enough issues with making sure you have enough plasma? Absolutely. Populations, obviously elderly. I mean, nursing homes, there was a study that came out of, I think, California where the nursing, I mean, it's got destroyed, 87% mortality for the nursing home. And almost everyone was symptomatic or sick. So that's a huge risk. Diabetes, everyone with diabetes that I've seen get it is bad. Obesity, heavyweight, I mean, talking pretty overweight, obese, definitely worse. And hypertension too, unfortunately, which, I mean, most people are going to have hypertension, it seems like, so that's a bad one. But I'm also biased, is that I'm seeing the intensive care unit and the people are hospitalized with it. I'm not seeing the primary care clinic side, where people may not know they have it. They may feel like, oh, I just have a cough and a fever and it goes away. I'm seeing the worst of the worst. So you have to take into consideration my bias from what I'm seeing inside of the hospital. And discuss risk factors. Is plasma an effective treatment? I didn't see too much, but I was looking at it from using it, giving it to this person, and then going to the next room. I haven't looked back at the data yet. I don't know if anything is available saying that convalescent plasma did anything. I pretty much everyone that I could get plasma on, I did. I saw, out of all the ICU patients, I think I saw maybe 2 or 3 leave the unit and not on a trach. And those people that didn't have a tracheostomy placed, they got plasma, and they almost all had an underlying immunity, like CLL or CML or some lymphoma, leukemia. Those are the people that I can remember leaving the unit looking, a little bit better than when they came in it. So in that population, maybe it's more effective than people who don't have, who have a good immunity. I don't know. That's something we're going to find out in maybe a year from now. And yeah, there was a strong shortage of plasma for a long time, and remdesivir. And it's unfortunately got to that point where you had to make a judgment call of, you have 2 patients, they're both very sick. Who do you give it to? It's kind of who you decide who lives and who dies. And I mean, unfortunately, most people in the intensive care unit didn't end up making it anyway. But it got to the point where you're deciding, and you gave it to this person over this person because of this reason. So yes, I've had a lot of issues with resources. Fortunately, remdesivir is back. It's shown to be a little bit effective in this. And then the plasma, I haven't had to use it for a few weeks. I've been here at Moffitt, like I said, so it's I'm not sure. We don't have a lot of COVID patients up here right now, fortunately. Was the MCAT the only part of your application that wasn't where you wanted it to be, or was it a combination? No, it was purely MCAT. It was purely scores. I did the volunteer stuff. I knew the people. I schmoozed. You got to schmooze. So I definitely schmoozed. I had the application is, they want your scores. And I had people who, the med school in Kentucky, they changed it. KYCOM, KBCOM, I don't know, the Kentucky one. And I interviewed there, declined. Oh, it's because of your MCAT. They verbatim told me it's because of your MCAT. We don't accept people with scores less than this because we want you to pass the curriculum. The curriculum is very rigorous, is what they say. And so people with lower MCAT scores typically don't do very well in medical school because it's a rigorous curriculum, which is complete, maybe there's some validity to it, but I never felt like I was failing out of any of my courses in undergrad or medical school or internal medicine. I've never felt like I was behind my classmates because of an MCAT score. So there's that. This is kind of off the wall question, but how important is reading speed and success in medical school? Medical school was PowerPoints. And so it wasn't necessarily the speed, it was the recall and repetition. So, you go through it the first time, you go through it slow, and you go through the next time and it's faster, and you go through the next time and you're lightning speed. I always went through all of my PowerPoints 3 times at minimum and color coded everything. And it's not necessarily speed because I wasn't reading books really. I was reading PowerPoints is what it was at the time. And so now when I try to read a book, I have to read it really slow because I'm not used to that. I'm used to bulleted this, and this. I'm not used to reading paragraphs anymore. So it's recall and repetition. Is your GPA a huge factor in finding a job in the medical field in general? Not at all. So GPA kind of falls out the wayside. As soon as you get medical school, your GPA, it from what you did in undergrad doesn't matter. And then your Mcat score, nobody has asked me my Mcat score since I applied to medical school. It doesn't matter. After you get in, that's the GPA in medical school. Maybe I was a pass-fail at OU, and a lot of schools are pass-fail. He's at the top of his class. He was, I'm not sure if it makes any difference if you're at the top of the class or the bottom of the class. You pass the class, and you're in less than 1% of the entire U.S. is doing it. So at the end of the day, you still have an MD or DO at the end of your name, and it doesn't really change a whole lot. Patients don't look at you and say, "What was your GPA? What was your MCAT score?" Nobody cares. If you can talk to the patient, if you can relate to the patient, you interact well. That is what at the end of the day matters, and not your MCAT score and not your GPA. So as you pass your classes, you pass the boards, you pass a lot of it's interaction with the people you work with, because nobody wants to, work with somebody they don't like. And so personality is at least half of getting in and at least half of staying in and getting a job, not scores. What else? But you should try to do well. Try to get good scores. Least favorite prereq class. Oh man, drama. I don't plays. What? I mean, I took it because it was, the shoe-in. Yeah, it's hard to pass drama in undergrad. So I don't remember a single thing from that class except for there was one play that had a revolving stage, and I can't tell you what it was. Yeah, that was pointless to do a lot of those classes. Anyway, I know that DO schools have an additional aspect of their curriculum that differs from MD. What is that aspect? That aspect is a philosophy, which is the holistic approach. And so it's taking everything into consideration about someone's background, their psychological background, their physical background, everything, and encompassing that in a diagnosis. And we do the same things. The only thing we do differently is called OMT or OMM, osteopathic manipulative medicine or therapy. And it just means that I'm pretty much a chiropractor with a medical license. You use your hands, you get really comfortable touching the patient. And that's one of the biggest things about medicine, is that a lot of people are comfortable laying hands on a patient and feeling, swelling, the rash, anything like that. It's a lot of hands-off stuff. And that's one thing. It's uncomfortable first to, palpate someone's sternum, palpate ribs, pubic bones, a little weird, but it gets you really comfortable with your patient. And so I always make sure that if I'm listening to lungs, my hand's on their shoulder. I don't feel uncomfortable with that. I've never had one person tell me, take your hand off my shoulder while you're listening to my heart or my lungs. Nobody's ever said that. It kind of brings more closeness to you and the patient, and it seems like they feel a little bit more comfortable with that. I took the USMLE, which is the MD boards, to get into internal medicine, or any field after you graduate medical school. You take boards. It's COMLEX for the DO and USMLE for the MD, and I took both just so I could get into an MD program. That seems like it's a little bit more scholastic, bigger hospital settings. That's what I wanted, was the big hospital. So I took both to get into an MD program. And so, yes, you can go get your DO and you can do MD programs, because that's what I did here at Infectious Disease, and that's what I did in undergrad and internal medicine too. So, and you're never limited. I have never had anyone say, "Oh, he's a DO. Don't listen to him." I've had a few patients say that. "Oh, I went an MD," and maybe one or two in the past 5 years that have said that. And your colleagues, nobody cares. Nobody cares about that. Favorite Dr. Burns story from undergrad. Oh my goodness. Oh, I mean, usually it was Dr. Burns making fun of me because I said something stupid. Those are always the good ones. My favorite Dr. Burns story was we were in molecular biology, and it was PCR and polymerase chain reaction, and it's tough to get. And I assume your exams are still the same way, where you have to draw out stuff. It's not an question answer. It's this question's 10 points, this is 15 points, draw the Krebs cycle from start to beginning, or start to end. And I could not get the PCR. You got the primer here, you got the arrow here going this way, stops at this primer here, and this next one goes there and then there. And he literally sat with me for an hour and a half, if not longer, and making sure that I could draw the PCR cycle from the start to finish. Then that was everything, because it clicked. I'm like, oh, this is it. I could still go into this board and draw you how PCR works with the primers and this area to that area. Just because he sat with me for an hour and a half, and I finally got it. But I'm sure he was frustrated. But he didn't let it off that he was. Very, very helpful. So Dr. Burns is one of the reasons why I'm here. So Yellowstone, a hot spring, and Dr. Burns floating away. Yes, and then Dr. Oliver doing the snake dance. I remember that one too. Yeah, good times. That was good old Andrew Pollard. What else? Anything else, guys? How often are med tech or med lab teams on call? I don't have any idea. I know here at Moffitt, they're like every 5 weeks. I have no idea how much they work. Do you ask them to run tests or someone else? So you put in orders, and then if it's a weird order, you get a page from them, and they say, "What do you want me to do with this?" But yeah, they're in their lab, and we're in the clinical setting. We put in the orders, and they are very, very, very good at what they do. They're essentially microbiologists. They look at this and say, "Oh yeah, this is a Citrobacter, this is a Klebsiella," and they got it down pat. "Oh, it's going to be a Stenotrophomonas because it looks like this. It's stenting a plate," and you're like, "I can't even see this." They're very good. So we ask them to do it. They do it. They clarify and tell us that, hey, we need to change this if we need to, but I don't know how often they're on call. And it's probably job specific, I would imagine. One of the other questions I forgot was someone asked me, what did I wish I knew going in about infectious disease before I went into it? One, I wish I would have known I was going to be thrown into a global pandemic and not know anything about it. Two, it's probably the longest 2 years of my life because I just want to get out and be done with school. But I'm glad I did it because I enjoy it. It's 2 years. 2 years goes by quick. It's almost done. But that time that you really want to be done and you're still in school and everyone else is out enjoying their attending salary, you're still here doing a fellow salary and stuck doing calls all the time. So, yeah. Any other questions?
Thank you very much, Dr. Horn, for your time.
No problem.
And, if you want to get this last question, you can go ahead.
Developmental disability syndrome. How are you prepared during school to manage these types of cases? During school, you're obviously doing the clinical work about, you learn about all the developmental disorders, not all, but a lot of them, the most common ones. Certainly have patients with developmental delays or other chromosomal abnormalities or anything like that. The glycogen storage deficiencies, those kind of things you do see. And it wasn't necessarily in school, It was more at internal medicine, where you have these patients with these diseases, with these disorders, with these conditions, whatever. There was a specifically clinic at UF. There was this, at UF in Jacksonville, where it was adults disabilities clinic, and we rotated there when we were on certain rotations, and it was in the mornings. You go there 2 or 3 times a week, and it was specifically patients with these developmental disabilities. And so that's, I mean, internal medicine, that's where that kind of came in play. But you certainly have patients that you know, in the hospitals and the clinics that have some of these disabilities, disparities. I'm not sure what the politically correct term is these days. I'll have to ask my sister that one. Yes, and Andrew Pollard says, pre-med club, rest assured, if you complete the biology biomedical track, you will be very medical school. Oh, there we go. He corrected himself. He went to Kentucky though, so I don't hold that against him for medical school. You'll be very prepared in medical school. There we go. Good job, Andrew.
Thank you so much for your time today. Can't imagine what we pulled you from, but we really do appreciate all that you do for medicine, and for helping us to know more about our own careers.
Yeah, no problem. I'll give you my Abraham has my personal cell number, and I'll give him my email number to you. Guys can like shoot me messages or call or whatever. If I have time, I respond better to emails and texts and phone calls. But he can, you can give me my personal information. I'd be happy to help with anything I didn't answer later down the road if you need help or whatever. It's, I always make sure that I take time to help people who were in my shoes a long time ago. It's a long road, very, very long road. But at the end, you breathe a little bit better knowing it's done. So yeah, just be kind, be aware, and trust science.
Words to live by, Dr. Horn. Thank you.
Yes, thank you, Cody, and thank you to everyone who attended today. We certainly will look forward to seeing, many of you at future pre-med club meetings as well.
All right, I'm going to sign off here. Thanks for having me, everybody. And let me know if you need anything else. See you, Dr. Burns.
Take care, Cody.
You too. Hey, there you are. How's it going?
Hey, that's good, buddy. How you doing?
I'm surviving. You
recognize that guy, Cody?
I don't recognize him with a mask on.
Yeah, man. It's good to see you, buddy.
Where are you at?
I'm in Columbus. I'm doing cardiology fellowship now.
All right. Oh wow, there you go.
Yeah. I saw you hating on the cardiology realm. The heart's the heart. I'm kidding.
You can sit me any day. How about that?
No, man, that's good. No, it's true. I mean, it's true though. So, stay healthy, buddy.
I will do. You too, man.
All right, Bubba.
Yeah.
Take care.
You too.
Dr. Burns, take care of yourself.
Thank you. I will. You too.
We will. And then there's old Dr. Cody Carter right here.
Hey, Cody.
Hey, good to see you guys.
Good to see you.
Yeah.
All right. Well, we'll be in touch. Thanks for the invite. If you guys have other pre-med clubs, just send us a link. We'll at least listen in.
Okay. Yeah, we'll definitely let you know.
All right. Sounds
Maybe
good.
get you guys to talk one day. So.
Yeah. Oh, yeah, man. So I was going to say, you said, I know we were talking about the spring. Maybe we could even do Zach, Cody, Carter, and myself, we're all in Columbus, so we might be able to do something.
Oh, that's great. You could all do something together.
Yeah. Zach's going into pulmonary critical care. He's doing his interviews now. Cody Carter's internal medicine, and then I'm in the first year of the cardiology fellowship. So.
Oh, very good. Great.
Yep.
Panel.
All right. Thanks, guys. Take care. Stay safe.
Bye.
Bye.
Yeah.